Okay, good morning, everybody. How you doing? So, before we get started, we have a great speaker for you next. But what I wanted to do was, given the presentations we had yesterday, what are your thoughts about after hearing those presentations yesterday? Anyone want to get up and say a few words about what it means for you now that it's sunk in, what you've heard yesterday? Any main themes that stepped out to you that you want to comment on, but just a comment or two about what you got out of yesterday's presentations?
Good morning. Oh, good. Okay. My name is Renice McKinley. I'm a case manager with Family Health Centers of Baltimore in Baltimore, Maryland. And what I was excited about and was actually talking about with my coworkers is that I feel like I'm better educated to present information to my clients about ways that they can stay healthier and things that they need to be concerned about in their care. I work with Ryan White clients, and it's things that I wasn't really aware of. So I'm always happy to come to trainings and conferences and things of that nature so that I can learn more information to bring back to them. A lot of times I can present it to them as simply as I possibly can, and they may not be at the point where they're ready to really act upon it, but later down the road, they'll remember, oh yeah, I remember hearing about that, or they may take action at that time, but at least I can make them more aware of things to ask their physicians when they're in front of them, things to ask their social workers, case managers, and things of that nature. So I was really inspired by what I heard yesterday.
Okay, thank you. Any other comments?
Good morning. My name is Brenda Samuel. I am a retiree, but I do some consulting work around and I do some teaching around the city, Washington, D.C. What I got is a conversation about sex. And I think that as a teacher, as a professor, as a consultant, for me, I think it broadened my whole perspective when I'm talking to clients and students about that subject, because that's a taboo subject. We all do it, but we don't want to talk about it. So I think for me, there was an awareness and awakening so that that conversation can start. Thank you.
Excellent. And I think in this forum, we should be having that conversation here. Another comment? Last comment, actually. We'll get started.
Good morning. I'm Shirley Howe from B-Sides, Baltimore City. I'm the addiction specialist in Special Population Service. I work with the homeless individuals. I was very impressed by the data about the at-risk people for HIV, and I was so happy to see the mobile unit for Suboxone and Methadone. That's a dream for Baltimore City. I know at this time we don't have the money, but that's something I hope to see before I leave the profession. Thank you.
Thank you. And you will be hearing more about that, though. I think the model that Jersey presented is something that's pretty unique and something that if the Institute can assist, we'll try to assist our other states in looking at that model. So you'll hear more about that. With that said, we're going to have our next speaker up, and this is Dr. Ron Manderscheidt. He's going to be talking about the challenges and opportunities of healthcare reform for improving chronic disease care. So Dr. Manderscheidt is Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. The association represents county and local authorities in Washington, D.C., and provides a national program of technical assistance and support. Currently, he's an adjunct professor at Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, and he's also the president of ACMA, the College for Behavioral Health Leadership. He was past chair of the American Public Health Association, and he's received numerous awards over the years. So, Ron is also actually one of our board members of the Dania Institute. So with that, I'd like to welcome Ron up to say a few words.
So when I came this morning, I asked Ryan, well, how's the meeting going? And Ryan said, this is very, very interesting. Listen carefully. Tomorrow was good. Tomorrow was good. So Ryan is really very pernicious because tomorrow will be good because of health reform. So I'm going to remember that, Ryan, and use that again here. So let me begin with several background ideas here as context for health reform. And I think the very first idea as context for health reform is that we are dealing with an issue of social justice. If you go back to 1944, when President Roosevelt gave his State of the Union address from the White House, he then went into his office and he recorded a second speech on human rights. The very first right he talked about was the human right to good health. Everybody should have a right to have good health. So this is how many years ago? More than 66, 67 years ago. Franklin Roosevelt laid out that vision. But there's several other things you got to do. So it's good to have the vision, but you got to have the action. One of the actions here is we value everyone equally. Think about that. Think about your own life. We value everyone equally. So everyone has a right to human health, and we value everyone equally. Then the conclusion is you must address the disparities in health and healthcare in the United States. And you do that by building systems that promote equity. That is one of the major contexts for the Affordable Care Act. The purpose of the Affordable Care Act is to reduce health and healthcare disparities and to promote equity. And if we actually play it out, we will expand our valuing all people equally, and we will expand the human right to good health. That is really the context of this. And this is not new. Franklin Roosevelt said this in 1944. This is exactly what we tried to do at the time of Clinton health reform in 1993, and now we're back trying to do the same thing again. So this is really a very positive thing. Tomorrow was good, basically, for us, including in the behavioral health fields. Now, that's a very broad philosophical level. Let me walk down another level here. In the Affordable Care Act, there are several things that are worth mentioning. The Affordable Care Act is very person-centered care. Person-centered care. Where have you heard that before? You've heard that in behavioral health care for years, literally for years. So in that sense, we're ahead of the game. It's also, the Affordable Care Act is also whole health oriented. Whole health oriented, meaning we need to consider not only a person's mental health and their addictive health, we also need to consider their physical health and, if you will, their spiritual health. We need to consider all of these things together and put the person back together. What whole health is about. Again, we have been working in the whole health area in behavioral health for years, literally for years. And because of these things, because it is person-centered and because it is whole health oriented, it then also is very empowerment oriented. It's empowerment oriented to the people who receive care, but it's also empowerment oriented to you as providers of care. There are huge, huge opportunities in the Affordable Care Act. So I want to start with that as my basic frame for what I'm going to talk about. I'm going to talk about two things. I'm going to talk about the changing model that we use, and then I'm going to talk about some of the basic pieces in the Affordable Care Act. So we would say, you need to awake. So we say, awake, 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 and listen carefully. The model is changing. Our concepts have changed. We no longer believe that health and disease are two ends of the same continuum. Think about that. For years and years and years, we assume here's illness, here's health, and you move back and forth on that one dimension. If you define that dimension that way, health becomes nothing other than the absence of illness. And that's been our model for years and years and years and years and years, long as I've been in the fields, long before that. Now we have a different model. The model says we have one dimension that's illness, one end of the dimension is being ill, the other end of the dimension is not being ill, but we have a second dimension of health where we have the situation of positive health versus less positive health. Very important distinction. As soon as you envision the underlying model this way, then you change your approach to a whole host of things. I'll give you some examples of this. If you look at things this way, you can actually have a situation where a person has an illness, but they also have a very healthy outlook and a positive orientation to life. If you have an illness and you have a very positive orientation to life, that will mitigate the effects of that illness on you. Take the reverse model. If you have an illness and you have a negative outlook on life, or you are depressed, that will exacerbate the illness. You cannot talk in those terms, those models, unless you make health a separate dimension from illness. So you can begin thinking about specific concrete instances where this is the case. Now let's take this then and apply it. Here's an application of this concept into behavioral health care. So you look at the lower right-hand corner here. You have people, high morbidity and mortality, little self-help or hope. So you have people who are ill and they do not have a healthy outlook on life. Lower right-hand corner. You can go to the left, to the lower left-hand corner, biopsychosocial interventions. You can move a person back and forth on that illness dimension through biopsychosocial interventions. I can give you pharmacy. I can give you various forms of treatment to move you back and forth. If I want to move you toward wellness, I have to do other things than biopsychosocial interventions. Go up into the upper right-hand quadrant. Things such as self-help, social support, changes in unhealthy lifestyles. And it's really only if I do both of these things, I do biopsychosocial interventions, and I do, in essence, wellness interventions, that I can move you toward recovery and health, the upper left-hand corner. That's the underlying model that we're now operating on, and that is the underlying model of the Affordable Care Act. We've been using this for a while in behavioral health care. Cite a couple of examples of this. My own research shows that public mental health clients die 25 years younger than other people. Why do they die 25 years younger than other people? Because of lifestyle issues. 46% of the cigarettes smoked in the United States are smoked by public mental health clients. 46%. Incredible number, if you think about it. Most of the people who are in the public mental health system also take second-generation antipsychotics. Second-generation antipsychotics have the known effect of leading to the metabolic syndrome, which then predates having diabetes or heart disease. Thirdly, living under a bridge. If you're homeless and live under a bridge, I can't expect that you're going to have very good health. And you go on and on and on with all of these factors. And fourth, these people don't have hope. You got to have hope here. So if I take all these things away from you, smoking, second generation antipsychotics, living under a bridge, not having hope, why should I be surprised that you die 25 years early? And that's exactly what happens. If I add substance use to that, there's a study in Oregon that actually shows the differential is 34 to 36 years for a person who has a mental health problem and a substance use problem. So substance use is adding another 10 years to that decrease in length of life. If you want to do something about that, you need to use the type of model that I've laid out here. You need both biopsychosocial interventions and you need wellness interventions. The wellness interventions that have been developing have been coming mainly from the field. They've not been coming from the researchers. They've not been coming from the federal government. They've been coming from practical interventions being developed by people in the field. And there are many, many websites that I could link you to that would show you that. So, with this as the framework and the model, let's walk down to some examples. So, what conclusions do we draw from this? Community, family, and social support do make a difference in one's health. Disease prevention and health promotion must be rooted in these upstream factors. You can't simply root disease prevention and health promotion in the healthcare system. It has to be rooted in your community, your family, and your own personal social support. So, how does this translate into policy? All policy, including health policy, needs to be oriented to what are called the social and physical determinants of health, which is what I was just talking about. Your community, your family, your social supports, which leads to disease prevention and health promotion intervention, which affects chronic disease care, which influences your health status. So this is the underlying model. We need to set up policies that do these things, policies that mitigate the negative effects of the social and physical determinants of health, including health disparities. We need to bring about disease prevention and health promotion, which impacts upon the age of onset of chronic illnesses, which impacts upon people's health status. Again, this is the underlying model, not the framework, but the model for the Affordable Care Act. So what are some things that are being done that fit into what I just said? So Healthy People 2020, the health goals for the United States for the year 2020 are based upon this very framework that I just went through. HHS is also developing leading health indicators. So those leading health indicators are going to be presented at the American Public Health Association in just a few weeks. What are those leading health indicators? They are the upstream factors that lead to downstream illness. So instead of simply measuring how many people have heart disease, how many people have diabetes, you're upstream how many people are obese, how many people don't exercise, how many people smoke, how many people use alcohol, and on and on and on down through these upstream health factors. The Centers for Disease Control has developed measures of well-being and health-related quality of life. It's going after the positive dimension, the health dimension, and how you would measure health. And CDC says you would measure health by measuring well-being and health-related quality of life. Well-being, what you think of yourself, and health-related quality of life, what you think of yourself in relationship to your environment. The American Journal of Public Health has just published the very first article that I've ever seen by a CDC staff person, and I think it's very interesting, it's by a CDC staff person, on the impact of positive mental health on one's health status. So one of the issues going forward here is how do we bring about a state of positive mental health in people? Critical issue, very interesting article. HHS has just issued the National Prevention Strategy, and one of the things I'll send over to Ryan and Kathleen is a copy of the National Prevention Strategy. Every one of you should have a copy of that. How many of you do have a copy of it right now? A few of you. 2 people over here. Only 2 of you? Every one of you should have a copy of that, because that lays out some of the key goals and some of the key strategies for prevention and health promotion. And so, bottom line again, the Affordable Care Act endorses all these things that I've just talked about here. Why should we care about this? We should care about this because chronic disease now consumes 75 cents out of every healthcare dollar we spend. And if you translate that into actual dollars, we are spending $2.2 trillion a year on chronic illness. Imagine what the difference could be if we could delay the onset of some of these chronic illnesses by simply a year or 2 or 5 years. What if we could delay the onset of diabetes by 5 years, or the onset of heart disease, or the onset of depression, or the onset of addiction by 5 years? Not even prevent it, but simply delay it. You're dealing with tens and hundreds of billions of dollars of difference, basically. Secondly, with a rapidly aging population, we will never get ahead of the problem only by relying on care. We're going to have to get into prevention. So right now we have about 36 million people in the United States who are age 65 and over. In 20 years, we're going to have 72 million people who are age 65 and over. We're going to double the elderly population. Imagine our healthcare costs unless we do prevention. Just imagine. We must get upstream to delay and prevent the onset of chronic diseases. The new framework and the ACA will allow us to do this. So I don't want you just to think, well, the ACA is a piece of legislation and it ties into money and da-da-da-da. It also ties into our philosophy, our approach, social justice. Okay? So with that, now I'm going to move into the second part of what I want to talk about, some of the key features of the Affordable Care Act. So the Affordable Care Act was passed in March of 2010. There are 2 versions of the bill. One version of the bill is a 2,300-page document. The other version of the bill is about a 905-page PDF. And I'm going to send Ryan the 905-page PDF. And you should all have a copy of that, not because you're going to read the 905 pages, but because if you have a PDF, you can go in and search. So if there's a particular term you want to search for example, one of the terms used in the Affordable Care Act is the term navigator, an insurance navigator. So if you want to know what an insurance navigator is, you can go in, put that word in, and all the instances of insurance navigator in that piece of legislation will appear. So this was passed in March of 2010. And it has 5 pieces, which you see in this overhead. Insurance reform, coverage reform, quality reform, payment reform, and IT reform. The first 2, insurance reform and coverage reform, get 2,000 of the 2,300 pages. Why? Because they deal with money. Quality reform, payment reform, and IT reform get about 300 pages. And all of those tasks are assigned to the Secretary of HHS to implement. The Secretary is given over 1,000 assignments in this bill. And I think we have a wonderful opportunity in these fields to impact upon how quality reform plays out, how payment reform plays out, and how IT reform plays out, because the Secretary is going to be out in the field asking for input, and is already out in the field asking for input in all of those areas. I've also put on this overhead all of the dates at which these various features become effective. So insurance reform becomes effective in 2014. Coverage reform is already in effect. Whether you know it or not, it's already in effect. The Secretary is given 4 years to do quality reform, 10 years to do payment reform, and 4 years to do IT reform. And what I'm going to do is quickly go through these areas so you know the highlights, and then also ask you a few questions. And I want to end early so we can interact and we can talk about this rather than me just talking to you here. Okay, insurance reform. The purpose of this piece is to provide new health insurance coverage to 32 million adults. These 32 million adults, for the most part, are either single people or childless couples. Adults with children are already covered in Medicaid, and or their children are already covered through the S-CHIP program. You say, why is it 32 million? I always heard it was 50 million. It's 32 million because we start with 50 million. I take out the 8 million children who don't have health insurance today. Every one of those children will have health insurance by the year 2018 as a result of the S-CHIP legislation. So I should be able to stand here in 2018 and say there's not a single child in the United States under the age of 18, irrespective of their parents' income or family situation, who doesn't have health insurance. That's what the purpose of that is, to take out those 8 million children. I'm down to 42. I have to take out, it's a various number, 6 to 11 million. They've used 10 million here. 10 million people who are on undocumented immigrants, because this legislation excludes undocumented immigrants, which brings me down to the number 32 million, which is the estimate we are basing this upon. 16 million of these people will get their insurance through new state health insurance exchanges, which are simply bazaars in which health insurance will be sold, and 16 million will get covered through Medicaid. The 16 million who will get covered through Medicaid will have 90% of the Medicaid costs paid for by the federal government between 2014 and, 100% between 2014 and 2018, and then 90% thereafter. So don't let anybody tell you this is going to break the Medicaid bank. It will not. There may be other things that the states are doing that are breaking the Medicaid bank, but it will not be this. This is a huge infusion of Medicaid money into the states. Absolutely huge. My estimate of this for behavioral health care is probably in the range of $60 billion a year. But that's Ron Manderscheid's back of the envelope estimate. The other 16 million people will be insured through the health insurance exchanges. The Medicaid coverage will go up to 135% of poverty. Above 135% of poverty, the person will go into the health insurance exchange. Anybody between 135% of the federal poverty level and 400% of the federal poverty level will receive a federal subsidy for their insurance. Again, the idea being we don't want to have a single person in the United States say, I don't have health insurance because I can't afford health insurance. So that subsidy will bring the price down to the level where the person can afford the insurance. Every one of these people, every one of these 32 million people will have an essential health benefit. So if you're following what's going on in this world right now, there's huge conversations going on right now about what the essential health benefit is going to be and what HHS is going to put into that essential health benefit. We in the Whole Health campaign have developed a recommendation for the essential health benefit for mental health and substance use. I'll be glad to share that with Ryan. And we did a draft in July. We circulated that. Now we're doing the second draft, which we want to turn in again by the end of October. Mental health and substance use, by law, are part of the essential health benefit. So we will not be left out here. The issue is how much we'll get into this. And I don't have time to go into this in long detail, but right now the debate and the trade-off is between affordability on one hand and comprehensiveness on the other. And there's a huge discussion underway literally as we speak here. Coverage reform. Now, several things in coverage reform are very important. So virtually all the things in coverage reform went into effect on September 23rd, 2010, which is 6 months after the bill was passed. Beginning on September 23rd, 2010, no one under the age of 19 can be excluded from health insurance because they have a pre-existing condition, which is huge. By January 1st of 2014, no one, irrespective of their age, will be able to be excluded from health insurance because they have a pre-existing condition. And we know virtually everybody who has a mental health or substance use condition has a pre-existing condition. And we also know that most of these conditions begin while people are teenagers. So this change is absolutely huge. People up to children and young adults up to the age of 26 can no longer be excluded from their family insurance policy. That's already in effect. And I've had many people come up to me and ask me about that particular feature. They say, you know, I'm a single mother and I have a daughter who's 23. Can she be covered? Of course she can. And that it's a universal coverage, so there's no test for this, etc. All you have to do is ask and the child will be put on the policy. This is also huge for behavioral health care because most people begin their behavioral health care in their early 20s, 5 to 10 years after they get the condition. So this is huge for behavioral health care. Third thing that's huge for us, there are no longer any annual or lifetime caps on insurance. Previous to September 23rd, 2010, virtually every one of you had a lifetime cap, probably either $2 million or $3 million on your health insurance. No longer true. You all know the story of the person who got schizophrenia. They first blew through their health insurance, then they blew through their family resources, then they ended up on Medicaid. Those stories should begin going away with the Affordable Care Act, basically, because of the elimination of the annual lifetime cap on insurance. One other thing I don't have on here, and should have a fourth bullet on here, there can be no copay or deductible for any preventive intervention. So if you're doing SBIRT, there can't be any copay or deductible for SBIRT, as an example. Quality reform. Huge, huge. This is where the secretary starts coming into the picture. So the secretary is charged with setting up health homes to address prevention and promotion and chronic disease care. So a health home is a place where a person can go and get all the care they need. So they don't need to go to 64 different providers for care. It's one-stop shopping, health home. And the goal being every single American will have a health home by the year 2020. And this has already started. So CMS has already issued an announcement for a health home Medicaid state plan amendment. And in that state plan amendment, you can focus the health home on persons with serious mental illness or persons with substance use conditions. The advantage of that particular state plan amendment is 90% of the cost of the state plan amendment will be paid for by the federal government for the first 2 years, which is far beyond the level of Medicaid payments in most states. So you need to inquire whether your state is actually working on one of these state plan amendments. The health homes will be operated by what are called accountable care organizations. So an accountable care organization is simply an organization that brings together behavioral health providers, primary care providers, long-term care providers, people who do prevention and promotion into a single organizational structure. CMS issued draft regulations on health homes and accountable care organizations and got a lot of comments, including comments from us in the whole health campaign, that we weren't happy with their draft regulations on accountable care organizations. We want the situation to be such that If you are a behavioral health provider, you can be a core entity to create an accountable care organization. We also want quality measures in there that reflect the delivery of behavioral health care services. And so we made those comments. We understand CMS is revising the regulation on accountable care organizations and so on. So another task for you here is finding out where your community is on creating health homes and also finding out where your community is on creating accountable care organizations, and is your organization actually engaged in negotiation with anybody to become an accountable care organization. Very important going forward. It also involves setting up a prevention and wellness fund, and I'm sure you've heard about this. This is $18 billion that's being given to the Centers for Disease Control to develop person-level and community-level interventions for prevention and positive health promotion. We, the behavioral health field, needs to be at that table so that we come out on the other side with prevention and promotion activities that are behaviorally focused. So the challenge here is working with CDC to do that. Payment and IT reform. The idea behind payment reform is a very simple idea, but very complex to implement. The simple idea is the goal of the Affordable Care Act is to move from an encounter-based payment system, which is what we more or less have everywhere now, where insurance companies and the federal government pay encounter by encounter, to a system that's a case rate, a person for a year, or capitation rate, a person in a population for a year. Very different payment system. Now, why would we want to change that? Because we waste huge amounts of, just absolutely huge amounts of money on the encounter payment system. When I worked on Clinton healthcare reform, we estimated that we wasted about $100 billion a year on the encounter system at that time. The estimate now is $300 billion. So in that 16 years, it's tripled. So we're spending $300 billion a year on the encounter payment system, which is more than 10%. We only spend about $2.7 trillion. So it's more than 10% of everything we spend is spent on the encounter payment system, and we get absolutely nothing for it. In behavioral health care, the estimate is about $13 billion a year, which is huge. So to put that into perspective, we spend maybe $100 billion a year in Medicaid on behavioral health care. $13 billion of that is being spent on the encounter payment system. And you all have had experience with that, where you will go to the doctor, a few days later you'll get a letter in the mail, 3 pieces of paper, page 1, you went to the doctor and the cost was $150, page 2, we allowed $28, page 3, you owe $56. That system costs $300 billion a year to implement. And there are just trillions of these letters going out here, trillions of these letters. And so we need to change that. What is the advantage of a case and capitation system? The advantage is you put the person back together. You put the person back together for a year, and it becomes predictable. Tomorrow was good, Ryan's comment, tomorrow was good. It becomes predictable what money you're going to have to care for that person over the course of a year at the beginning of the year. You won't know in an encounter system whether you're going to have money tomorrow. Very different, much more predictable, a very positive and good thing. Say a word about IT reform, and then I'm going to quit on IT reform. The goal is that everybody in the United States have an electronic health record. The estimate of the cost savings in electronic health records to the whole system are absolutely huge as well. The estimate in the Senate, if everybody in the United States actually had an electronic health record and was functioning the way it should be functioning, the savings would be about $700 billion a year. Just an incredible amount of money. And even if it's only half that, but 350, it's an incredible amount of money. We need to move toward those electronic health records, and people always say, well, you know, what about privacy? What about this? What about that? My answer always is you got to do both. You got to have privacy, and you got to be able to assure privacy, but you also have to have the person plugged into the system. It's not fair to the person not to have an integrated electronic health record. If they're getting care over here from a behavioral health person, they're getting care over here from somebody else, and neither side knows what the other is doing, the combination can literally kill someone. There are numerous examples where people have died because they have conflicting medications from different sources, and there's no integrated record. One provider has no idea what the other provider is doing. So there are strong moral reasons and strong financial reasons and strong care reasons why we would want to have good IT. Again, there's a long story behind this in behavioral health care. We are trying to get the resources for the behavioral health care field to implement electronic health records. Right now, we have a bill in the Senate, S539, which would extend the benefit that was already extended to primary care to behavioral health providers. We expect to have the House bill introduced in the next week or so. We need your support on that bill as it goes forward this year. And it's not controversial. Nobody down there is arguing we shouldn't do this. I guess what they're arguing about is how much it should cost, basically. And everybody who's involved in this on the Hill understands we need to do this as a field. So we need your support for that particular piece of this. So what is the bottom line on all this? And I'm going to wrap up here and we can talk a little bit. The Affordable Care Act is moving us toward person-centered care that addresses whole health. And it's doing this by the health homes. It's doing this by putting in prevention and promotion and paying for them. The Affordable Care Act has the potential to move chronic care upstream to delay or prevent the onset of chronic disease and to improve well-being and health-related quality of life. That's absolutely huge. In a population where we have 155 million people already who have chronic disease. And we must not permit the ACA to be revoked here. So even though the Supreme Court might decide next summer that insurance can't be mandatory, we want the other pieces of the Affordable Care Act to stay in place. All these various things that I talked about need to stay in place and would not be changed even if we had a negative finding in the Supreme Court. So virtually everything I talked about here is on our website. This is the web address. And in fact, on this website, there are 12 webinars on the Affordable Care Act. So I did one of those. I did an hour-and-a-half webinar on introduction to the Affordable Care Act. And then we go on and we have a webinar by a person from HHS on the Medicaid expansion. We have one on health insurance exchanges. We have one on health homes. We have one on accountable care organizations. We have one on prevention and promotion and so on. So if you want to go up on the website and yourself dig into any of these areas, that material is all available to you and it's available on our website. So with that, and this is my contact information. I'm going to make sure that Ryan has these overheads. He has the National Prevention Strategy. He has the CDC strategy on positive mental health promotion and so on, so he can circulate these materials to you. I've also written a number of commentaries on the Affordable Care Act, and I'll give him a listing of those commentaries. So let me stop here and open it up for comments or questions on the Affordable Care Act. Anybody? Yes, please. Please introduce yourself and say who you are.
Good morning. My name is Deidre Johnson, and my organization is Heart to Hand. We're located in Prince George's County. You talked a lot about medical homes, and although I agree with medical homes, you talked about the systems being all together. How are you going to make sure that people are involved in creating those medical homes? And sometimes small organizations who assist with navigation, they don't have the resources to have the primary care doctor, but they can provide that one other service.
Right. Okay. Very good comments. I think on the Affordable Care Act, we have to be proactive. We have to be out there and become engaging of others. You can't wait for somebody to come knocking on your door. So that's the most important point. And within that, there are some key points. So as I said, in your own community, I'm sure there are entities working right now, this minute, to develop accountable care organizations. Who are they? Are you working with them? You know the answer to that, and if you aren't working with them, you need to find out who they are, and you need to be working with them. Absolutely critical, even before these regulations come out from HHS. So it's about being proactive in your own community and environment here. Secondly, you raise the issue about navigation. The Affordable Care Act actually does talk to the issue of navigation. So on the state health insurance exchanges that I talked about, one of the functions of the state health insurance exchange is to have people who are identified as health insurance navigators help people who've never had health insurance before navigate the health insurance exchange. That extends into the care system. So there are insurance navigators, there are care navigators. We've called these people care coordinators or case managers in behavioral health, but the concept is identically the same. And one of the challenges, if I were going into the next level of this, would be talking in each of these areas. How do you become engaged in outreach to people who have behavioral health conditions? So of these 32 million people, we know already 10.5 million have behavioral health conditions. So my question to you as a behavioral health provider, how are you identifying these people, and how do you intend to reach out to them in your own community as these insurance systems come online? And the function you would be using to do that would be a navigator function. So if you focus on navigation and that's what you do, that should help you very much make the adaptation into the Accountable and Affordable Care Act, basically. Make sense? Okay. Others here. Please.
I also want to go back to the health homes. Hi, my name is Maurice Hatton, and I'm retired, so I want to go back to the health homes. Okay. Do you anticipate that those health homes are going to end up being in hospitals and already well-established outpatient clinics?
Okay, so very good question. So the initial draft of the Accountable Care Organization regulation said, well, there are two entities that should create ACOs. One are hospitals, and the other are primary care practices, which is what we objected to. So it wasn't even outpatient clinics. It was only hospitals, and it was only primary care practices. So we said, this is ridiculous. There are many, many ambulatory outpatient clinics that are health clinics. Community health centers could not form ACOs under the original regulation. We could. A mental health organization or a substance use care organization couldn't form an ACO. So we objected to that. We expect that that will be changed in the next draft of the regulations. That remains to be seen. You need to watch for the next draft to come out. If it's not changed and they come out with the second round of the interim final, then we'll go back again and continue to work on that. We're not going to give up on that issue. There are three key issues you have to succeed on here to survive. One is you have to be in the Medicaid expansion, the health insurance exchanges. Two, you have to be in the ACOs. And three, you have to be in the essential health benefit. And failing any one of those, then we will be in trouble, and we don't want to fail any of them. So on the issue of health homes and the ACOs, you have to stay tuned for the next draft of the regulations from CMS, which probably will be out in fairly short order here.
And then one question around the area of coverage. Insurance companies have done a super job of not covering dental health. Super job.
Okay.
what's happening there.
Okay, understand the question. So yes, the Affordable Care Act takes on dental health. Well, we worked on the leading health indicators. As one of the leading health indicators for the United States, we actually put an indicator in there on dental health. It's basically for children and for adults, what proportion of children and adults have untreated dental disease. It's a very simple number, but at least puts focus on that area as a critical area going forward. And we know that's a critical area for people with behavioral health problems. So it's in there, got to keep advocating for it, basically. Anybody else? Yes, please, over here.
Good morning. My name is Bola Idowu, and I'm from the SEEDS Healthcare Training Institute, and we're based in Colombia. We do a lot of outreach and community health development. And my observation, I have more of an observation. First, to appreciate you helping us to break down the ACA in such a way that, you know, when we're in the community, we're able to explain it, because we do get a lot of questions. And so I really want to say thank you for that. My other question of interest is, you know, how do we, going forward as community-based organizations, try to get into this larger agency? Because sometimes we feel a type of blockage, you know, and it becomes a challenge to actually penetrate through some of these institutions that have already been put down. Thank you.
Okay, very good, thank you. And that question is very similar to one of the preceding questions here. It's really, how do you become part of an accountable care organization? And so I would say, in part, what I said to the previous person, you have to be out there and understanding who in the Columbia area, in Howard County, is actually working on this, and are you at that table in Columbia and in Howard County? One level. Another level, are you linked with other behavioral health providers? So are you speaking with a common voice? In the Coalition for Whole Health, we try to speak with a common voice for mental health and substance abuse. So it isn't 110 organizations at the table speaking individually, it's speaking collectively. You have a much more powerful political voice if you can speak collectively. Third, you need to look at what legislation the state of Maryland is actually developing in this area. And I will send to Ryan, I will send to Ryan the legislation that was drafted for New Jersey on accountable care organizations and the legislation that was drafted for Oregon. Where is Maryland on this issue? And as Maryland takes up this issue, is the legislation going to reflect behavioral health organizations? So there are multiple levels that you need to become engaged on, not just as a person, but as a field in Columbia and Howard County around this issue, basically. So I'll send to Ryan these documents and he can circulate them so you can see what other states are actually doing. Anybody else? Yes, please.
Good morning.
Good morning.
My name is Fatima Meadows, and I work for the pediatric department out of New Jersey for the New Jersey Medical School. My primary location for my job is inside of the juvenile prisons. What, if any, is this going to affect how healthcare is going to do for inmates across the country?
Okay. Excellent question. Excellent question. So, in my role at NACBID, okay, this one's on. Doesn't have the same problem here. So, the issue you raise is a very, very important issue to us. For example, this morning there probably are 800,000 people in the county jails in the United States. 600,000 to 700,000 of those 800,000 people have behavioral health conditions. 600,000 to 700,000. So one of the issues in the previous legislation and regulations has been, when a person enters the criminal justice system, their Medicaid coverage stops. And I'm sure if you work in that setting, you have dealt with people who used to have Medicaid coverage and it's become suspended, or they've completely been thrown off the rolls, which is actually illegal. So what we have done, we've said, okay, we need to work on this issue, and we in NACBID and also in the National Association of Counties have been working on the Hill to extend the Medicaid coverage from the door of the jail to the point of adjudication. We say, until a person is adjudicated as a criminal, they still have the same rights that everybody else has. Why are you suspending their Medicaid? So we're working on that for current Medicaid enrollees, part of our work. The second piece of our work, which brings in the Affordable Care Act, the Affordable Care Act extends Medicaid coverage for the new enrollees, these 16 million people I'm talking about, to the point of adjudication in the criminal justice system already. We don't have to go and fight for that because that's already there. So this legislation, plus the work we are doing right now, should help address the very problem that you're talking about of people having no insurance coverage once they're inside the criminal justice system. And what we got to do is we got to help these people who are current Medicaid enrollees then have the same rights as the new Medicaid enrollees going forward here. And there's just a huge amount of money involved here, and the counties are literally dying financially from bearing the cost of all this care without any support from Medicaid for this population. It's a huge, huge issue for us. Anybody else here before we, yes, please.
There. Hi, my name is Rosa White, and I work for Glenwood Life Counseling Center in Baltimore, Maryland, in the city. I have two questions. S-chip, is that the same as M-chip that we use in Maryland?
Yes,
for children?
So, yes.
Okay.
It's called the State Children's Health Insurance Program. S-chip.
Okay.
State Children's Health Insurance Program.
All right, and what is IT? I had no idea.
IT is information technology.
Okay. And my question is, the Medicare Reform bill, does this ACA impact individuals with the Medicare who don't have any money for their supplement insurance and their pharmacy?
Yes, the answer is yes, and it's in various ways. So one of the ways it will impact upon people with Medicare coverage is the fact that CMS is very concerned about people who are dual eligible. The dual eligible is a person who is eligible for Medicare and they're eligible for Medicaid. So Medicaid, they're eligible because they have low or no income. Medicare because they have worked previously under Social Security, or they are the adult child of someone who's worked previously under Social Security. Those dual eligibles are the most expensive group cared for by CMS, basically. So CMS is very concerned about that group, and they have initiated a grant program with the states to begin developing program integration between Medicaid and Medicare for that population. How does this relate to behavioral health care? We think that probably 35 to 40% of the people who receive behavioral health care under Medicaid are also dual eligibles for Medicare. So that's one part. Second part, on Medicare itself, Part D, the donut hole will be closed. And so for a current Medicare beneficiary, the first payment of $250 toward closing that hole was made in 2010. The next $250 is being made this year, so over 4 to 5 years, we've completely closed the $2,500 donut hole. And then the third piece, which is, I think, unresolved, is what is the Congress going to do about physician payments under Medicare? And you have to stay tuned to that. That issue is up to bat again this fall, and I don't know what the outcome of that will be. So there's several pieces in play here, basically.
All right, thank you.
Anybody else? Okay, if not, let me tell you one story before I leave. And if you don't remember anything else that I said, you can remember the story. So it's a true story. So last year was the 200th anniversary of the birth of Abraham Lincoln. And as soon as I mention Abraham Lincoln, most of you immediately have this picture in your head of this very severe man in a black suit with a black top hat. Probably not a person who had a very good sense of humor, lots of problems, the Civil War, all this stuff. Well, actually, Abraham Lincoln had a wonderful sense of humor. And whenever he would go out and talk to a group, he would always tell a story that was focused on that group. And these stories were put together last year in honor of his 200th birthday. So this is a true Abraham Lincoln story. So Abraham Lincoln went out to visit with a group of doctors in Washington, D.C., and he said, "Gentlemen, I want to tell you a story. The patient was in the hospital, very, very ill, in the hospital bed. The doctor comes in, patient says to the doctor, "Doctor, am I going to die?" The doctor said, "Absolutely not. You're not going to die." The patient said, "Doctor, how could you possibly know that?" The doctor said, "Well, there are statistics about your type of illness. For everyone who has your type of illness, out of every 10 people with the illness, 1 lives and 9 die. In my practice, the last 9 have died." True Abraham Lincoln story. So with that, let me go here. So, okay.
Hello? Okay, perfect. Thanks again, Ron. I appreciate you taking the time to talk with us today. There are 2 words I want to leave with you, given Ron's presentation. One is actually advocacy. It's something that Ron has said in his presentation is that you need to be aware of what's going on and advocate for yourself. Now is a time for us to say what we need, what we want, and put our voices out there. The policies aren't set in stone yet. It's an opportunity. And opportunity is actually the second word. Because I know with all the changes happening, everybody feels like things don't look so good, it looks pretty bleak, but really and truly with change comes opportunity. And I think if you take the opportunity and advocate for yourselves at this time, it's a great era for us. Like I said earlier to Ron, yesterday was great, or today was tomorrow was excellent. So it works. Thank you very much.